Welcome to the Thyroid Fixer podcast. I'm your host, Dr. Amy, and we're diving deep into the world of hormones, especially for all you fierce women in perimenopause and menopause, and everyone struggling with hypothyroidism. So if you are battling weight gain, you're feeling like shedding those pounds is an impossible feat, if you're dealing with plummeting energy levels, gut-wrenching fatigue, or a libido that seems to have left town, then you're in the right place. And let's not even start on the hair loss. If these symptoms are sounding all too familiar, you have found your tribe. My goal is to educate, empower, and shake up your world. Remember, I want you to embrace every inch of that badass woman that you truly are. So if you're ready to dive in and fix things, let's go. So this is going to be a game changer for you, and you can probably hear the excitement in my voice. The latest introduction, the latest member of the family to the Fixer line is Metabolism Fixer. And this, oh my God, I formulated this just for all my people out there that need to lose weight, that need help in the weight loss department, that can't lose weight no matter what they do, that feel like they have a slow metabolism, and that might be thinking of trying all those peptides out there, you know, the Beverly Hills soccer mom drug of choice for weight loss peptides. Or even if you're on them already and you're like, man, these are really expensive and I'm still not losing weight, add in Metabolism Fixer. Here's what I did. I took the power of T2, which increases your basal metabolic rate while you are sitting there watching Netflix. You're burning fat while you're watching Netflix. I combined it with a very unique patented ingredient called Suppressa. Suppressa has multiple clinical trials backing its efficacy in reducing your appetite, decreasing snacking, and providing way more control over your food intake. It is amazing. We also see improved emotional well-being, just decreased food cravings all around, reduced hunger, and weight management. Add on top of that, we have green tea extract. We have purple forest purple tea extract, both of which affect the metabolism in a very positive way without the jitters of normal fat burning supplements out there from the 1980s and 90s, right? The ones that made you feel like you're having a heart attack. You will not have that in any of my supplements, Thyroid Fixer or Metabolism Fixer. But Metabolism Fixer, ooh, yeah, we kicked it up a notch. It is in powder form, so you can drink it through your day. It's going to flavor your water. We got orange crush and refreshing citrus. I love them both. It is going to keep you under control all day long. So you throw a couple scoops in your water bottle in the morning, throw a scoop or two in your water bottle throughout the day. You will have fat burning and appetite control the entire day for what? An eighth of a price of the peptides? Oh my God, you can't go wrong. So grab some Metabolism Fixer today. Please let me know how you do on it. I am super excited for you. Super excited. Dr. Anna, I am so happy to have you on because people need to know your knowledge on hormones. There's only so much I can talk about on here. People start tuning me out. I like having guests on here that reiterate things that I tell my audience and my patients, and that also obviously dive much deeper with the knowledge base that you have. So thank you so much for coming on.
Oh my goodness, it's my pleasure. I love having these conversations too.
Let's just jump right into sex and libido because, you know, you say that and that keeps the listeners listening. So we're just going to start right there. And one of the reasons I'm starting there is because I hear from my patients, from my audience, I get so many questions about libido. And this is a big point of frustration for women, especially because they want to be sexually intimate with their partner and they want to enjoy it. They want it. And, you know, many women just, whether it's a physical symptom of vaginal dryness or whether it kind of goes into the just lack of desire to even participate, we're seeing this low libido crisis permeate women from their 30s to 60s and 70s. So let's start there. And I'm just going to hand it right over to you and ask you, where do you like to start when you have someone tell you, you know, it's just not there anymore for me?
Yeah, you know what? I've been researching this since 1999, researching it, experiencing it, investigating it, working with patients and couples about libido, sexual desire, and working with them to resuscitate it. And through these years, I found that it comes down to three main issues. Like, why don't we want the intimacy? What's going on? Why don't we want the sex? What's going on? And goes beyond sex, right? Sexual health is necessary, in my opinion, for optimal health. You know, we cannot forget this, whether it's male or female. So for men experiencing erectile dysfunction, women experiencing, low desire or difficulty orgasm, or it's taking me too long to get there, or it hurts when I have sex. And all of these things create barriers. And there's no area that I have found in my career in medicine, now going over 30 something years, there's no area where people are more vulnerable. When it comes to sexual health and intimacy, the most confident of us steps into an area of vulnerability. And that is true. So, with having conversations with respect and openness and authenticity is critically important. And so through this, I found that it comes down to three main areas. One is the issues of desire. Issues of desire. If you feel sick, if you feel unhealthy, if you are having hot flashes in the middle of dinner, if you're feeling bloated and gassy, it's hard to feel sexy, right? If you're not sleeping through the night, it's hard to feel sexy. Mm-hmm. And so the issues of desire can be for many reasons. Health, medical medications, for instance, can keep us from, for example, something as simple as an antihistamine now in pollen season can decrease your ability to have orgasm and create more dryness. So something simple like that. And then, so issues of desire. And then there's disconnect in the relationship. When cortisol or stress hormone is winning, mm-hmm. It affects our love and connection hormone, oxytocin, and that is losing. And so we have this disconnect, this physiologic disconnect or emotional disconnect with our partner. It can be for a number of reasons. And the third, and really most easily treatable usually of these, is discomfort. If you have pain or discomfort every time you do something, why would you want to? So the vaginal dryness, pelvic pain, vulvodynia, lichen sclerosis, endometriosis, if you have pain in any way, you need to see a GYN. You need to see a gynecologist. They need eyes on you, look at what's going on, maybe biopsies if needed, and to assess assess the vaginal bacteria. Just like a good functional doctor is checking your stool. We want to check the vaginal microbiome or the bacteria within the vagina, your first line of defense. And so the other thing is, if you're having intercourse or sexual play and you're having difficulty with orgasm, or you're having discharge odor, like fishy odor after sex, or bladder infections after sex, then, again, why would you want to? That is negative feedback. So you can check in with yourself and say, and oftentimes my clients never make the connection. And then we reverse the problem. They're like, I didn't realize I was avoiding it. It was so subconscious. And so that really, it's powerful. It's powerful to recognize that our bodies are designed for pleasure. From a biblical perspective, our bodies are designed for pleasure. And with pleasure, we increase oxytocin, the most important hormone of our body, the hormone of love and longevity. I like to say love and longevity. And so increasing oxytocin is healing and therapeutic to both our physical body and our relationships.
So we hear more and more about oxytocin these days, especially with all the peptide websites that come out. But I don't think people know how to increase their oxytocin. I don't even know. I mean, I've seen the oxytocin sprays on a couple of the peptide websites, and I've always wondered, I'm like, should I get that and try that? But I don't have a clue about it. There are natural ways to increase our oxytocin as well. So what do you like to use with your patients when you're trying to increase that particular hormone?
Yeah. So first, there's a series of questions that I ask, and I have an oxytocin quiz on my website. So I ask those questions and you kind of get a score evaluation. And often I can tell sometimes by looking at someone. For example, if like classic autistic patients, paler, not making eye contact, cold, clammy hands, that's low oxytocin. Those are telltale signs of low oxytocin. You give that person oxytocin, or you get their body to make more of it, all of a sudden smiling, flushing, eye contact. So I got to tell you a story on this. So first of all, so I have a patient in my medical practice, and she was in her mid to late 40s. And because of stress, relationship disconnect, she was having sexual health issues and also anxiety and some depression. And so I had her on some oxytocin, and, always want an individual to make more of it naturally. So we'll run into a list in a little bit about ways you can increase oxytocin naturally. But so I was prescribing her oxytocin, and she said, as I recognized my symptoms and I started feeling better with the oxytocin, it really was empowering. She goes, well, my son, I looked at him and he's sitting on the couch. He graduated high school, was in football, and now he's just sitting there. He's not motivated. He's taken a couple college classes, but, he's just like, I felt like he was really disconnected, Dr. Anna. So I gave him one of my lozenges. And I was like, okay, first of all, don't ever do that. Secondly, what happened? And she said, well, like he just seemed better. He just seemed better. So I thought I'd bring him in. So I saw her son, and I gave him, a questionnaire, that very classic. He was on the spectrum, maybe from traumatic brain injuries from football. It's possible. Yeah. And we're working this up. So anyway, so I shake his hand, cold and clammy. He's not making eye contact to me, looking away, very pale skin. And I said, okay, I'm going to just test you with this oxytocin. I gave him an injection. So sometimes I will give a small dose of an injection with lidocaine because oxytocin will burn. And I gave him an injection, and right immediately he has that flush on his chest, his ears pink up. He's looking straight at me. He's smiling and starting to have a real faced eye-to-eye conversation. It was so instantaneous. Her mom's like, told you so. I'm like, yeah. So we'll work with him. And then as we work on the other issues, like, why isn't your body making oxytocin? Is cortisol too high? I mean, I go through a whole sequence to see. And then again, I prescribed him some oxytocin. But like the prescription of oxytocin is a crutch to just remind your body what it feels like, to address the underlying issues that are keeping it from being produced at optimal levels. Often it's that cortisol oxytocin issue in some of my patients with PTSD and traumatic brain injury. There are other issues as well. But so addressing those underlying issues and getting you to make more of your own oxytocin naturally. But there's ways that I can prescribe it, such as with nasal spray, lozenges. And I like the rapid dissolve tablets because you can usually break them in half, and you can usually, for sexual health, use it vaginally the same time. The troches or the rapid dissolve. So, but you've got to work with a pharmacy that knows how to make it well, because it's very heat sensitive and it will denature the protein
if it's not made correctly. Right. And especially with all these sites popping up where you can DIY yourself peptides and medications, you definitely want to work with somebody who knows what they're doing.
Yeah, and these are powerful hormones. So, I mean, these are powerful hormones. And if anything we give ourselves could potentially suppress our body's own ability to make it. We definitely don't want to be reliant on exogenous oxytocin.
Right. Absolutely. So when we're moving into the other hormones, you had mentioned one of the causes of low libido is simply pain and vaginal dryness and pain during intercourse, which we normally see in perimenopause, menopause, as women start to lose their estrogen. But you even see it before that, correct? And what is that tie-in with estrogen or estradiol and that vaginal dryness?
Well, definitely. I see, one of our hormones in both men and women in our 20s peaks and starts to decline in our mid to late 20s, and that's DHEA. So DHEA is the first of our hormones to really, for us to see a significant decline. And it's a precursor to testosterone and estrogen. So as a result of lowering levels of DHEA, we'll see lowering levels of testosterone and estrogen. And so DHEA we've studied DHEA for vaginal dryness now for over, I've been following the research, over 15, maybe 18, 20 years now, and looking at DHEA for vaginal health and vaginal dryness. And just a few years back, I think it was 2016, I know, maybe 2018, a pharmaceutical DHEA vaginal suppository was approved by the US FDA, Food and Drug Administration. That's prasterone. So it's a DHEA vaginal suppository that has been used. Now, prior to that, I was compounding DHEA and topical, and I had released my product, Julva, which is topical DHEA and plant stem cells from the alpine rose. And the reason I prefer for vaginal dryness issues, changes, because estrogen works on, typically physicians will say, well, here, let me give you some vaginal estrogen. So number one, you've just given a woman a little bit more to worry about, because if she's sexually active and has a male partner, that male partner will get that estrogen. And so then they're having erectile issues. They're starting to feel more emotional. And there are times we want our male partner to have more estrogen, but, and I know as a gynecologist, sometimes I see cream that was inserted 2 days before in the vaginal tract when I do a pap smear or an exam. So when I create a Julva, I want it to absorb very, very quickly at time of application, that it's absorbed. And DHEA is safe in men up to 10 times the level for women. So you don't have to worry about, I just inserted it, we can't have sex now, or we got to wait, several hours, or, the timing of thing. And I'm a busy woman, right? Like last thing I want to worry about, right, is timing.
Right.
So I think that's important and to consider. And so absorption and ease of use, and that it feels good. And compared to many of the estrogen, vaginal gels that we're using in our body, all of the prescription ones that I know of, except for maybe Vagifem tablets, but I'm not exactly sure what else is in that tablet. But in estrogel and Premarin vaginal cream, there are parabens, hormone disruptors, chemicals that are actually adverse to can cause harm to the vaginal tissue, not to mention gets absorbed into our bloodstream, and our body's dealing with that too. So, that never made sense to me.
Well, and I did not know that Julva contained DHEA until I actually met you and got to know you. Many of my patients and listeners use Julva. And, at first I thought, okay, well, this is just for vaginal lubrication, just like another lube that you buy at the store, right? And then I met you and I learned so much more about Julva containing DHEA. And here's the other benefit, ladies, is that you don't have to beg your doctor for a DHEA suppository that they're going to look at you cross-eyed and go, why would you want that? How is that going to help? Because they don't know. I mean, you know that, Anna. They don't know. They just don't. So I love that this is over the counter that women can use.
Yeah, absolutely. And without having to worry about a suppository and the expense. If your insurance doesn't cover prasterone, that's hundreds of dollars a month.
Right. So it's kind of like dual action. You get a little bit of the DHEA and it's lubricating at the same time. So that's helpful. That's beautiful.
Yeah. And the plant stem cells, the alpine rose plant stem cells have antiviral, have collagen rebuilding properties, are, have used in some of the top line cosmetic products. And they're, the alpine rose is just this beautiful flower that blossoms in the harsh conditions of the Swiss Alps. And so you think, like, for me, that just exemplifies femininity.
Oh, yeah. Good call. So is this something that we should be using every day just for vaginal health, not just on the days where it's time to have sex?
Yeah, definitely. And, ounce of prevention's worth a pound of cure, and sooner rather than later. So I'll give you an example. I have a client who, Nancy, was 56 years old. She had been raising her children, had been divorced 20 years. Now they're off to university, and she's out dating, and had found what she called the love of her life, an exceptional relationship. And so I was so excited for her. And she called me about a couple months later, and she said, Dr. Anna, I'm on my third urinary tract infection. Doctor says I need to just take a daily antibiotic. And that's it. She goes, but I wanted to talk to you about this. And I said, well, first of all, did you take that third antibiotic yet? And she said, no. I said, okay, this is what you do. And I said, first of all, use Julva daily and use it during sex. And let's work on that. Use Gelva, take an oral probiotic and increase your vitamin C to 4,000 milligrams per day. And she never had another urinary tract infection. And when she was engaged to be married to this gentleman, she said, Dr. Anna, the fact that our intimacy was on its hinges, basically, it was on its edge, because every time we had sex, I was going to get a urinary tract infection. I had to take an antibiotic, and I was doing this. So when we have sex, I'm not going to get a urinary tract infection. I know that would have driven us apart. And said intimacy was so important to me, this ability to connect and be intimate. And now they're married. I think they're at their 2nd year anniversary. So, and I find that true, whether it's a new relationship or an old relationship. It's that, what are the consequences that are disrupting your sex life? What is causing a disrupt? And if it's related to dryness or vaginal discharge or discomfort or urinary tract infections, look, none of us have to deal with that. We can restore that completely. And, for Nancy, who had 3 urinary tract infections, she hasn't had another one.
That's huge. That's a big,
I
big
see that
deal.
all the time. Yeah, I see that all the time.
So what are the other benefits of, let's say on DHEA, what are the other benefits of DHEA as a hormone?
So DHEA is one of our, I consider it one of the strongest hormones. Again, it's a precursor to testosterone and estrogen. And if we have optimal levels of DHEA, we have more resilience. So I consider it a hormone of resilience. So in other words, our immune system's stronger, we bounce back sooner, we have less incidences of cancer. So it is, and stronger bones, decreased risk of breast cancer, less osteoporosis. The list goes on for that. But DHEA is just a powerful, very important hormone for both men and women. We want our DHEA in women to be around, ideally around 150, and men around 250. And there was a time, and I see this in patients too, DHEA levels in the teens. And that was true for me. And that's when I was burnout, stressed, depressed, hormones were a mess. And it really started me on this journey in early 2000s, looking for alternatives and answers. And that's what makes me do what I'm doing. So restoring when times of stress, you're going to plummet your DHEA levels.
And you're going to plummet your progesterone. So we'll talk about that too. I want to go through all the hormones. But before we move into these other hormones, how do you like to test DHEA? You just mentioned the optimal lab values, and we talked a little bit about this before we started. So I want to get your take, and I want the audience to hear it as well. How do you like to test all of the hormones? Do you have different methods like saliva versus Dutch versus blood for each hormone? Or do you like to do it all? Do you like to mix and match?
Yeah. No, I always tell my clients I will test every body fluid you have at some time or another. So it's true. Our body fluids tell us so much. And so typically I will look at everything for baseline levels and looking at, baseline levels over time. But let me just give you an example. If a patient comes into my office to see me and they have complaints, I want to do blood work right there because that's my fastest turnaround time. I get answers right away. I'm checking other things like lipid panels and thyroid. And so I'm going to do a quick blood test and look at their hormones, look at some of their metabolites and see what in vitamin D level. So I need to know that information right away to optimize their hormones. So I'm going to look at those things.
I'm checking in with you. How's your energy these days? How's your skin? How's your muscle strength? These are things that are very, very important to me. And I know just from research that after the age of 30, our mitochondria starts breaking down. And these are the powerhouses of the cell that provide us with muscle strength and better skin and abundant energy through the day. So I've added in something that I wanted to share with you, Timeline Nutrition's MitoPure. So when we look into research into healthy aging, it really focuses on that pivotal role that our mitochondria plays in our body. And without our mitochondria working at top notch, then health is just declining. And that's not what we want. Daily wear and tear on our mitochondria is inescapable, but we can do something about it now. Timeline Nutrition's MitoPure is the first supplement that has been clinically shown to replace and rebuild damaged mitochondria. And this results in a boost in cellular energy. And actually, research has shown that individuals experience an increase in muscle strength and endurance without even altering their diet and exercise routine. So, I mean, I can personally attest to feeling the difference. I am now going to ask you to feel the difference. So I invite you to go to timelinenutrition.com. They're giving my community 10% off of MitoPure if you use the code Dr. Amy. So you are going to go to timelinenutrition.com/Dr. Amy and use the code Dr. Amy, DRAMIE. So timelinenutrition.com/DRAMIE and use the code Dr. Amy at checkout.
And then for follow-up, so I will, usually either do a repeat blood analysis, but I typically will do a urinary analysis because urinary hormone metabolites will show us so much. There's two tests that I use, either the Dutch test or the HUMAP test. So those are the two labs that I'm most familiar with urinary hormone testing. Mm-hmm. Also, both of them will show us the cortisol pattern throughout the day. So it's looking at accumulate hormones over time. Then, when do I use salivary testing? So for baseline, I may use salivary testing. Say, for example, if I haven't seen the patient yet and they're not on any hormones, or I definitely want to look at their cortisol pattern throughout the day, I'll do a baseline salivary test. I used to do a lot more than I do now. I think with the advancement of urinary hormone testing and the diurnal pattern, being able to look at their hormone fluctuation or their daily pattern it's been really easy to do.
And I've always heard, I heard this analogy a while ago that doing something like a Dutch test with urine metabolites on a woman who is not on hormones yet, and she's perimenopausal, menopausal, we know her hormones are declining. If you do a Dutch test at that point of time, and many of my patients have come into my world already, they spent the money and they did a Dutch test and we're looking at it. I'm going, yeah, but this doesn't tell us much because you don't have any hormones. So doing a Dutch test on a woman not taking hormones or who doesn't have hormones is like doing an audit on a 16-year-old bank account, right? You're just not going to see that much. There's going to be a few transactions in and out, and that's about it. But then once you start someone on BHRT, bioidentical hormone replacement, then we move into then that's money well spent, basically, because we're seeing how you're utilizing those hormones. Am I saying that correctly? Do you have the same kind of outlook on the Dutch, or do you do it even before you start someone on hormones?
Well, oftentimes, no, even if I have a client who's not on hormones and I'm curious about their estrogen metabolites, or if I'm curious about their cortisol pattern, or I need to prove it to them. Yeah. That there's something going on and that their levels are really low, or, then it helps us to do it and to look at that proof. Then we have something to compare it to. Mm-hmm. And also looking for any red flags, any surprises, any significant abnormalities. It can really help us. But I think when we're testing, and you and I have been clinicians long enough, right? Like I have, clinically able to see the improvement in the energy and vitality of my patients clinically, right? Mm-hmm. And through their symptom score. And so, but I want to see I want them to be convinced what gets measured gets managed. And that increases compliance for most of us. And I want to tell a story about a patient that was in my office for follow-up this week. So she's 70 years old. She was 69 when she came to see me, had a history of breast cancer, and was really struggling. Her medical symptom score was 50, in its high 50s. And so we want it like less than 10. We want that score less than 10. And so her score was high, but she's, very strong, strong, mentally active. And she said, I have no desire to have sex. It hurts. I can't even, my husband and I have been together. I want to say they were together over 40 years at that point, together over 40 years. And, they love each other. The marriage is important. And she goes, I'm not organized, and that's not like me. I usually keep everything in order for everyone. And I'm really struggling with the history of breast cancer. They told me no hormones. And right. So I said, it's really important that we see, okay, what's your baseline is, and let's work on, supporting you. So for me, I put her through my Keto Green 16 plan and have her do her homework. And for everyone, their homework is my book, The Hormone Fix, because there's 10 chapters in there that each address, well, if you consider spokes on the wheel of our health. So I am having her do that, and I start her on Julva for vaginal and vulvar health after presenting the research and clinical research, all available on my website at dranna.com. And supporting her with progesterone at night to help her sleep, to get a better night's sleep. And, for me, my basically foundational supplement is my adaptogenic formula, Mighty Maca Plus. So put her on that, have her follow the dietary and nutrition guidelines and support detoxification. So she came back. So she was, let's say I started seeing her in July. She just turned 70 last month. And she's like, Dr. Anna, I've been going for 5-mile runs again. I feel so much better. And like, that's how to live as a 70-year-old. And so what I said to her is, your body is inhospitable to cancer. Like she goes, I feel so free, because when I have a cancer patient, they're just waiting for the next shoe to drop until you address the underlying issues where there's a problem, and then they feel empowered. So in working with clients, looking at the hormone metabolites, looking at the cortisol patterns, I can help safely guide them in their resilience and their physical capability to heal better, faster.
And I'm so happy that you brought up the cancer aspect and post-cancer therapy with hormones, because that's such it's an ongoing topic. I don't think we can talk about it enough, because it really, as soon as I release this episode, I'll get a question a week later about, well, my doctor said that I need to stay far, far away from hormones because I have a history of cancer, or I had breast cancer and it was ER negative, positive, whatever. And they're so fearful of hormones. So that makes me want to transition into the true benefits of, when we're talking about estradiol, progesterone, and testosterone, the benefits to our bodies, as opposed to what we're hearing from conventional medicine and from the media, that hormones will cause cancer and they're bad and we should avoid them. Yet we hand out birth control like it's candy to anyone, whether you're a teenager or 50 years old. You can go get birth control in a heartbeat, but you can't get bioidentical real hormones that are just like the hormones that your body produces or once produced. So can you speak to the benefits or the protective benefits of all of the sex hormones?
Yeah, definitely. So when, and I lecture on this, I'm lecturing next weekend for 4 hours on this topic. And so there's a lot of benefits, right? There are a lot of benefits. And hormones incorporated into your body in a healthful way is regenerative and restorative. But there's the unhealthy way too. And so, and again, like, not everyone's a candidate. You got to clean up your lifestyle. You've got to clean, you can't be, I tell my clients, we've got to, if you're not going to drive through McDonald's every day and expect a prescription from me, I'm sorry. We've got to make some changes. We've got to make some changes, and it's empowering. Estrogen didn't cause breast cancer. So, right? Like, it just didn't. And the estrogen disruptors and the hormone mimickers and the hormone disruptors and the toxins and inflammatory chemicals within our system, those cause cancer. So we know this now in revision of the Women's Health Initiative trial that was published or held in 2002. Since republished, when we looked at that data initially, because I was I've been a scientist. I was a medical researcher before I went to medical school in physiology, exercise physiology, and respiratory physiology for the U.S. Navy. So I have a long history of the scientific method. So when I looked at, and plus I was part of the HERS initiative, working on an arm of the HERS trial, which was the basically hormone replacement for heart health in women, also showing increased risk of cardiovascular disease. So when that study was published, and what we now know from revised and continued analysis of those cohort, the women that were part of the study, we know that estrogen-only arm did not increase breast cancer, nor does it. But however, oral estrogens are risky, and I typically post 50 don't have clients on oral estrogens because they increase your risk of stroke and heart disease and can be pro-inflammatory, increasing your HSCRP, so your C-reactive protein. And there's plenty of research, published on that in cardiovascular journals, et cetera. The toxin is the synthetic progestins, not bioidentical progesterone, because we've had studies since 2005, 88,000 person studies published by Dr. Fournier out of France looking at bioidentical progesterone forms, identical to our body or body identical, compared to synthetic progestins, such as Provera, which was studied in Women's Health Initiative trial, causing a significant increased risk of breast cancer, as compared to other differing forms of progestins that have a varying effect and increased risk of breast cancer. But the only one with no increased risk of breast cancer is the bioidentical progesterone. So we have good data on that. But why would we use these hormones? If you consider the hormonal cascade from cholesterol, we're making progesterone and pregnenolone, the two mother hormones that are necessary for a cascade, a rainfall of other hormones, or a symphony of other hormones. So we have this hormonal cascade from cholesterol to progesterone and pregnenolone, and then to one arm's going to go down cortisol. So we, versus going down to DHEA and then to testosterone and estrogen. So if we look up here at progesterone and pregnenolone, those are mother hormones. We think of progesterone, progestation, that's how it got named. It supports pregnancy, but it's important for brain health. It keeps tryptophan active in our, and keeps it from degrading. So that helps you with improving serotonin production and improving melatonin production. So start at the top. That's what I would say. We're going to start at the top. I typically start when I'm intervening, I start with detox. Let's clean up your pathways and get your body to use more of what it needs to make naturally, respond to your natural hormones better. So the hormone, for me, it's a keto green hormone detox that I put clients on with the adaptogens and detoxifiers. So in the supplement regimen, I call it my keto green detox. So I start there. So your body's using and making more of your own in a healthier way. And then using DHEA and progesterone and pregnenolone, I created a combination over the counter because many clients have difficulty getting it. So using progesterone and pregnenolone has been shown to improve brain function, memory, cognition, recall, sleep, energy. There's so many good reasons for progesterone. Progesterone is brain, breast, and bone protective. So we know that there's many studies regarding progesterone. I published some on my website as well at dranna.com. So progesterone has all these neuroendocrine benefits too that are important. And what I recognized way back early in my practice years is that when I started giving clients progesterone who'd had a hysterectomy for years before, and I was giving it to them for whatever reason to balance their hormones, make them feel better, and get a better night's sleep, they'd come back and say, Dr. Anna, I feel like the cloud has lifted. The world's gone from grays to multicolors again. And then I really dug into brain and progesterone research, and there's significant amount of brain and progesterone research. So it doesn't make, with or without a uterus, using progesterone and or pregnenolone, especially menopause and beyond, into our second spring is, for me, a foundational part of the foundations, the healthy foundations.
I'm so happy you said that because I hear chatter, I see it at least in Facebook forums, about not using progesterone if you've had a hysterectomy, if you don't have a uterus. And it just blows me away because of exactly everything that you just said. It's so beneficial. It has arms that reach out to different areas of your body for protection. Why wouldn't you use it? Why wouldn't you? And then the other hormones as well. We have testosterone, we have estradiol. Those are also very protective. And I actually didn't know until recently that testosterone is protective of the breasts against breast cancer. And then we have the host of benefits with estradiol as well. The bones, like you said, bone, heart, brain, everything, reduction of dementia and Alzheimer's. That's huge.
That is huge. And Dr. Rebecca Glazer was a breast surgeon. She's published significantly since early 2000s on testosterone and the breast and the anti-estrogen effect of testosterone. However, the consequence in some of us, we will convert testosterone to estrogen in more so than others, and how that estrogen is detoxifying is really important to look at too. So looking at those levels, testosterone, and this goes for guys too on testosterone. If they're not having their estrogen and estrogen detox pathways checked, they're being mismanaged. They're being mismanaged. If they're not getting an exam, and women too, if you're not getting your exams or your pap smears, you're being mismanaged. So you've got to look and see what's happening to the end organs, to the tissues. And in thinking about testosterone and men, I was doing a radio interview not too long back with a couple of guys like, oh, I just feel so much better since the testosterone. Yeah, my, what did he say? I forget, some crass statement. My, whatever, are shrinking. So he was talking about his balls shrinking, but he used some crass words. I can't remember what. And he goes, I'm good with them. But you don't have to be. I mean, because right there, that's telling you your body's shutting down its natural production of testosterone, and you're just 100% supplementation. He goes, I'm good with it. But I said, but what if something happened? What if you couldn't afford it? What if you couldn't get it anymore? The FDA blocks it. Then all of a sudden, you're at a high risk of suicide. You're at a high risk of suicide because your body's not making it. And we know men who stop testosterone abruptly have an increased risk of suicide, depression, and it's devastating. So we don't, and I'm very conscientious of how we're giving hormones so that we're not suppressing our body's natural production, so that we're, have a safety net too when we need it.
How do you feel on that note when you have, because I get this question a lot, women who are, let's say, menopausal, we look at their labs, estradiol is the classic, less than 5, non-existent. Progesterone, less than 0.05, non-existent. Testosterone levels are coming in at a 9 or a 5 or a 3, which I've seen. And they ask that question, well, will I have to be on hormones the rest of my life? My answer is always like, you're not going to magically make more unless you're Benjamin Button and you plan on aging in reverse. Your body's not going to kick into high gear at the age of 55 and start making adequate amounts of hormones. So at that point of time, are you okay saying, yes, you're going to be on hormones the rest of your life, but who cares? Because they're going to give you life and give you a good one at that.
And I do think about that statement and look at our centenarians. If we look at the longest number, the areas with the highest concentration of people over 100, none of them are on hormone therapy. What are the things they're doing in their quality of life that has maintained their body's ability to produce hormones and quality of life and longevity and cardiovascular health and bone health and sexual health, all of those good things. So I never want to interfere with that. So because we're in, the individual that's in front of me, if she's in her mid 50s and her hormones are flatlined, I can resuscitate those hormones. Like with adaptogens, with detoxifications, with beginning meditation, and then I use hormones as a crutch. And, I do believe I'll be on progesterone and pregnenolone till I die. I do believe I will be on that till I die. But at some point, the adrenal glands are designed to be supportive. So we have to mix what we can do as physicians and, prescribers or, with supplementation with our body's innate ability to repair. And I don't want to take one away. And I think, I've known several, and it's really specific in men. I've seen several men who were on high levels of testosterone, very famous, including Dr. John Chrysler, who committed suicide, stopping his meds, depressed, didn't, whatever. And, was the depression from stopping the meds, or was the depression from what else? I mean, I'm curious. We don't know. We don't have an answer. But there's scientific studies published regarding those risks of acute depressive episodes after abrupt cessation. And many physicians don't know that connection. And so it's really important to understand that connection. Another, a case after case after case. So you have to look at physiologic effect of what we're giving or making naturally or what we're prescribing on behavior,
Right. Right.
and the
Very true.
consequence. I'm very conscientious of that. And the same thing with testosterone in women. I remember one of my first patients who had a history of, where I got started back in 1999 with using DHEA and testosterone post breast cancer. And the patient was, loved her husband, but said, she was, how old was she? 63 when she came to see me, 5'10", 150 pounds, silver haired, black horn, horn rimmed glasses, and just, a dynamo. And she said, Dr. Anna, I'm dry as a bone. I have no desire for sex. I love my husband. I'm a woman of the 60s, and I'd rather die than live this way.
Mm-hmm.
She said, help me. And I was like, oh, shit. I was in my first year out of med school. I'm like, oh, my God, what do I do for this woman? And I went to the research. Plus, she was a CEO of her biotech company. And so she brought me research looking at DHEA, testosterone, and some solutions, and filled my plate with it, and I dove in. And so I worked with her with hormone management. I will tell you that, fast forward 20 some years, at 83, she published a book, her own biography, and she was just the year before skiing the black slope. So I'm like a dynamo, right? But in between what happened, so about 6 years into working with hormones and management and everything, she divorced her husband. And he said to me, you think these hormones caused this? Caused her to have an affair, caused her to whatever. And he also was dealing with prostate cancer at the same time. So there was a lot going on. But that seeded enough information to think, of course it could. Potentially, the testosterone can increase desire, can increase dopamine, can increase novelty-seeking behavior. And so it led me to counsel, if you start thinking thoughts or acting in ways that aren't true to your character, let's look at what the hormones are doing, right? There's a double-edged sword with all of these. And I think it's important to recognize that your physiology affects your behavior. Too much, too little. It's the Goldilocks principle. We got to get it just right, but always honor the body's natural design. And if our body is not making our hormones, if we're flatlined at 50, which we should never be, why? Why? Always asking why.
Digging deep. And I think the lifestyle changes are really the hardest thing for people to do, because you and I can give hormones all day long, but it's what you said before about sitting down with a person. How's your stress? How's your lifestyle? What are you eating? Are you sleeping? Are you meditating? How do you detox? And all of that is just so important that I think I love talking about it on this podcast as well, even getting into the lifestyle, nutrition, and the sleep component, because too many people think that hormones are the be all end all, and they're fantastic. I love hormones, right? You and I love hormones, but unless you do all the things, the hormones might react differently in your body. You might not get the benefit. You might get the side effects and without the benefit. So I'm glad you brought that up as well.
Yeah, no, I agree.
And thank you for your stories too. I love stories. I love stories of patients. So
I have so many. I'm just thinking this week alone.
Oh, I know. If we just dig into our patient bank, there's all kinds of different situations and stories, and I love it. But Anna, thank you so much for coming on and breaking all of this down. I really wanted to dive into the different hormones and tie it back to sex, because libido and sex, just like I said in the beginning of the show, it's on the forefront of so many women's minds. It's often not talked about because it might be an embarrassing thing. They don't want to bring it up, taboo, whatever. Right. But hey, on this show, we talk sex, we talk poop, we talk about it all. So it's important to discuss it, right? It's important to get it out there and be real and say, listen, you're not alone. There are plenty of women out there and men dealing with low libido and performance issues and dry vaginas and erectile dysfunction and just not being into it, not feeling it, not being able to orgasm. And so there is help. There's definitely help. And it might be a variety of different modalities that you need to incorporate, but there's help out there. So I just want to thank you for coming on today and sharing your stories and your experience.
Thank you. Thanks for having me, Amy. I love what you're doing, and it's so powerful in this message. I mean, be right, and then thyroid's a huge part of it. So, without correcting the thyroid, we're running off balance.
Definitely. It's all connected. It's all connected. So we're going to put all the links in the show notes to your website so they can learn more about you and read all the research that you just mentioned, get your book, and also to Julva, because if you're not using it yet, that's going to be something you want to incorporate in. It's not, and one last question for you on that. I'm going to make the statement, but instead I'll hand it over to you and ask you, it's not harmful for anyone to add in, right? I mean, do we need a DHEA level before they start using Jolva, or is this something that is gentle enough that every woman can start incorporating?
Really, women can start incorporating. I always say mid 30s to 40s, it becomes like part of your cosmetic routine. We start to see laugh lines, smile lines, lip lines, it's happening down there. And that's where we get infections and we lose elasticity, we lose lubrication. So, clitoris to anus, the most important real estate of our body, and being able to apply it topically to that tissue makes a quality of life move.
Beautiful. Well, thank you, Dr. Anna. Thank you. And we will be having you back on soon.
Thank you.